Evening, everyone. Welcome to tonight's webinar, COVID Care in the Community, Sydney HealthPathways update. So thank you for joining us for tonight's COVID update. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. We also extend that respect to any Aboriginal colleagues who may be joining us today. I'd like to welcome our two guest speakers tonight, Dr. Kate George, who is an Inner West GP and also a clinical editor for HealthPathways Sydney, and Dr. Owen Hutchings, who's the clinical director of RPA Virtual Hospital. Now, tonight's webinar will be recorded and it will be available on Cessna's very own YouTube channel within the next couple of days. Now, tonight's also the opportunity for you to ask questions, so please post your questions on the Q&A and we will answer them during the chat, and I'll also be directing some of your questions back to the speakers. There'll be at least 15 to 20 minutes for time for questions, so please, some extra questions would be great. You will also receive a link to the evaluation survey following tonight's presentation. Now, look, can I hand over to Dr. Kate George? Kate, over to you.
Thank you, and thanks for inviting us to be part of this evening's information. I'm going to talk to you this afternoon about COVID-19 care in the community update from a Health Pathways perspective, really just taking you through what we've been doing at Health Pathways and how it all works in with the way we're all working in general practice. Next slide, please. So tonight, as Brendan kindly just said, it's me and Owen. Next slide, please. So learning outcomes for tonight. So by the end of the activity, we're hoping that you will be able to use Health Pathways to help you manage your COVID positive patients, to identify patients who need escalation of care and know how to escalate care using local resources. Next slide, please. So just a brief outline of what we're going to go through. I'm going to give you a background to the COVID-19 pathway development and collaboration that's happened in that space. I will show you without too much detail, because they're very detailed, and I think the important thing is for you guys to go through them in your own time and really digest the vast amount of information in them. But we'll have a look at some of the key COVID-19 pathways. I'll run through a summary of what's recently changed in the COVID space, and then Owen will talk about escalation of care and advice, the role of RPA Virtual, some information about pathways to sotrovimab and where that would and would not be appropriate. And then, as Brendan said, we'll have some questions and answers. So next slide, please. So a bit of history about the Health Pathways COVID-19 response. So through 2020, 2021, there's been a lot of collaboration at Health Pathways community level. The Health Pathways community is the group of all the different regions of Health Pathways. And we realised very quickly that all the regions weren't going to be able to do their own thing in terms of getting information up around COVID. So the concept of lead region pathways was developed, and that's where specific regions took ownership of specific pathways, and then the other regions could tag on and automatically get the updates as they happened. As you all know, things changed incredibly quickly. So through that time, the COVID care, so for our thankfully small numbers of patients in general, that was largely provided by the district and the virtual care services with support from the PHNs, particularly in the aged care space. So move forward to spring this year, Delta's happening. I think there was, at many levels, there was a urgent need for a more flexible and responsive structure. And that was in response to realising that with increased numbers, the current model of care was not going to be able to cope with that, and that we really needed to extend some of the COVID care, particularly for the milder cases and the lower risk cases, to general practice. So there was collaboration between Health Pathways and all sorts of levels of our healthcare system, with the Agency for Clinical Innovation, the Ministry for Health, the college, lots of conversations happening. At Health Pathways we developed a concept of a New South Wales state collaboration group, where Dr. Louise Delaney and Dr. Martina Gleeson led a small group of clinical editors who looked at creating some really specific pathways in a different pathways format to help you manage and support your patients. And the main goal there was to reflect the dramatically changed models of care that were going to come in. And that was before we even knew about Omicron. So all of this was happening in the background. Throughout, there's been really strong collaboration with Health Pathways and Central and Eastern Sydney PHN and Sydney Local Health District, and especially RPA Virtual in terms of the clinical services. This slide just gives you an indication of the pathway usage. There is the COVID-19 active case management pathway, which has the more detailed information about COVID management. And as you can see, the usage has just skyrocketed, not surprisingly, given the cases. The self-care patient triage and support page has also increased, but less so. And I guess that's reflecting the fact that a lot of this self-care stuff, the patients largely do themselves, but I'll show you the detail of that in a minute, and we can talk that through. The other pathways are also being used, but to a lesser degree. The other point I wanted to make is that whilst you can see that a lot of the COVID pathways are being used, this only accounts for about half of the activity of what's happening in Health Pathways Sydney. So I'm really pleased that everyone's still finding all the rest of the content helpful and useful, and that you're able to be using those pathways as well. Next slide, please. So just looking at what COVID-19 pathways we've got, and I've put this side by side just for the purposes of the slide, but when you look at the content down the left-hand side of the Sydney homepage and open the COVID-19 button there, you can see all the different COVID-19 pathways. The ones I want to focus on tonight are the PPE, infection control and exposure response, the self-care, the active case management, some support pathways, and then the request pathways, which are largely about when I need to find what to do with something and where to go and who to call, I can find it in there. Just note also that there are the other pathways, the RACF, if you're doing RACF work, that's recently been updated. The post-COVID-19 conditions pathway, that's a lead region pathway which Sydney is taking responsibility for, and that will be updated as things develop, and there's a lot happening in that space as well. Next slide, I think. Thank you. So just wanted to give you a few little tips, one of which I only learned recently. The first one is part of the structure of this new pathway is to see what new and important changes are. So at the top of the active case management pathway, the self-care pathway, and a couple of the others, you can see this drop-down box, which is new and important changes, and that's updated regularly. The second, so yeah, keep an eye on what's happening with those changes. The other one is if you're, and this is the one I learned about, is if you're looking for something specific in a pathway. So for example, if you're in a vaccination pathway and you're looking for resources related to immunocompromised patients, you can, on the right-hand side of that pathway, hit expand all, and then just hit Control F, so Control Find. It'll give you a little window up the top, which you can type in your search term. So immunosuppression, for example, and it'll take you to all the information within that large detailed pathway in relation to immunosuppression. You can use that with any of the pathways, not just in the COVID-19 pathways. So next one, so just to highlight the PPE infection control and exposure response pathway. So you'll probably be used to our our still current format, but not for these pathways, with assessment, management, and request. In these ones, we've sort of focused more on what does the GP need to know at a specific time. So this one covers general infection control in the practice, PPE stuff, what to do if you have to see a patient who has infectious symptoms, home visits for patient with suspected or confirmed COVID-19. And I'll just emphasize there that there's no expectation that people have to go and see home visits, but there might be an occasion where a GP might choose that as an appropriate thing to do, and how they can protect everyone involved in that situation. What to do if you have a staff exposure in the practice or community, and what to do if a staff member or patient has been infectious within the practice. There's links at the bottom of that page to referring patients to GP respiratory clinics if that's thought to be an alternative way of managing a symptomatic patient. ED referral to escalate, of course. CESPAN links for assistance with PPE supply, and Safe Work New South Wales if that is necessary. Next one, please. The COVID self-care patient triage and support pathway goes through a bit of emergency response stuff, which is about practice preparedness. So that's in the top drop box. And then really this pathway is largely dealing with the questions that people might ring up and ask you when they're at home looking after themselves. And these are generally the patients who are very mild. You've probably all got experience of this already. Hey, I'm feeling fine, but I'm still breastfeeding. Is that okay? I'm taking blood pressure medication. Should I continue with that medication if I'm not eating and drinking very well? Responding to concerns about household contacts and how to manage that, isolation concerns, mental health concerns, after hours numbers, and particularly this has the numbers to give patients for them to ring specifically. And then the one that I know I've been getting most of the calls about really is the de-isolation planning. When can I get out of here and what's the deal? Next slide, please. So the active case management, this pathway is really for people who are at higher risk or who have some more significant symptoms. So this is the full general practice care. And this will give you the information about things to be worried about and things to escalate and how to escalate. So the red flags are always the pretty serious stuff, and they're just all defined, and this is all aligned with the ACI guidelines as well. So these are the things that you either send people to hospital for or escalate somewhere. Next slide. And the next part of that is broken into two main parts, which is your initial and ongoing telehealth monitoring during illness, what you might be doing for which patients, what questions to ask, looking at their social background, looking at their comorbidities, assessing the household really, because I think a lot of these cases are actually households. We're not just looking at one person, we're often looking at multi-generational situations. And then, so that will take you through what you should be doing in that situation. And then the day 6 to 7 telehealth consultation and follow-up. I'll come on the next page, I'll come to what to do for different risk groups. The day 6 to 7 telehealth consultation is really about finding out whether people are better, not better, are they up to being released from isolation, what else is going on at home, what else needs to be done. Do they need work certificates? What sort of clinical follow-up do they need? So in request here, we have the red flags, which reflect what I showed you before, and the description of what to do. So what to do if someone's really crook, ring 000, send them to ED. There are local processes for hospital escalation, so notifying on-call respiratory consultant. After hours, the on-call respiratory consultant can be the person to ring if you want advice. If they're not critically unwell but seem to be getting sicker, you can seek escalation to the hospital-led COVID service, which in our case is RPA Virtual. The New South Wales COVID-19 care at home support line is not really suitable for that, so go straight to our local services. If someone's not answering contact attempts, consider contacting police or RPA Virtual for a welfare check. And if a patient needs transfer of care because a high-risk patient develops more severe symptoms, or if you're worried about anything, or if you want advice or to talk about the monoclonal antibody therapy for eligible patients, you can contact RPA Virtual as well. For general advice, your other option is to ring the care at home support line, and there is a GP option on that now where you can go straight through. You don't have to sit with the general queues, but can pop through to specific GP support. And then, yes, the isolation support, which I think is on the next page. Oh, sorry, the protocols first. So high-risk protocol. Again, I'm not going through this detail. It's merely to show you that it's there in the pathway, but follow-up is based on risk protocol. So there's a high-risk protocol, a low to medium risk protocol, and depending on their risk factors. And this will give your indications as to how often to monitor and how often to review, ideally via telehealth, but by phone is okay if that's the only option. And there's also indications in this part of the pathway for budesonide inhalers, though I did hear the other day that it's a bit hard to get that at the moment. There's information about escalation plans and contacts, and isolation supports information if you need it. So next slide. So the isolation support shows local services, New South Wales services and national services in many areas that patients might need support. Domestic family violence, financial support, including there's the COVID isolation payment that takes you through to the Service New South Wales link there. Food support, if people need food support. Local councils have some service. There's deliveries options locally, and also mental health support. And we also have the other pages sitting alongside this, which are adult mental health support and online mental health therapy for adults. I guess being isolated at home might be a good time to do a This Way Up course or something else if patients are well enough to do that. And yeah, New South Wales services and national services reflect that as well. Next slide, please. So what's recently changed? All patients are now self-managing and self-escalating if symptomatic or at high risk. A positive RAT is now accepted for diagnosis. That can be uploaded to Service New South Wales via the website or the app, and the patients go through a patient survey then. I think there's a bit of a loop here that we need to just be a little bit careful about. Some patients, particularly patients who may have challenges with health literacy, might slip through the loop and not necessarily self-identify appropriately. So I guess if we come across anyone who is high risk, who hasn't been triaged as such, we should use our escalation pathways. Routine pulse oximetry is not recommended unless indicated by symptoms. Some high-risk people that largely RPA Virtual will be looking after will be having pulse oximetry. A smaller number of GP managed cases will be. The new news in the past couple of days, which most of you have probably caught up with, is booster vaccine can be given 3 weeks after completion of their primary course. So that's whether the 2-dose course or the immunosuppressed patients 3-dose course. The 30-20 rule relating to video and telephone consults has been delayed till the end of June. The 12-month rule, having the requirement to have seen a patient within 12 months, still applies for video and phone unless the patient's in isolation under a public health order. And that includes infected patients in isolation and also close contacts in isolation. The level C phone item number's been reinstated till the end of June as well. And thanks to our colleagues who've lobbied hard for that to happen. The New South Wales, I mentioned before, has a dedicated option for GPs, and the number is listed there. And the also new advice in the last day or two is that the GP clinical advice line at RPA Virtual, we now have an extra CNC working with them, which is fantastic. And that the phone line has been extended from 8 till 6:30 Monday to Friday and 8 till 4:30 on Saturdays and Sundays. So a lot of thanks to everyone who's been involved in developing that advice line. It was sort of brought up as an issue early on. It's like, if we're going to be monitoring patients in the community, we really do need some clear support. And thank you for everyone involved, both at the district and at CESPN, for facilitating that and make sure that that's happened. COVID-19 requests. This is your request page. This is where you find, this is your go-to page to find how to get stuff, I guess. So it's fairly self-explanatory. Your drop downs give you the information for whatever you need there. Next slide, please. And my last slide on this before I hand over to Owen is really about medical practitioners' health. And I know there's been a lot of publication and publicity around everyone in the general practice and health setting looking after themselves. But I just wanted to highlight that we do have a specific pathway called Medical Practitioners' Health. It will be reviewed shortly, and I think our new name really needs to be Health Carers' Health or something similar, because the issues apply to everybody working in primary care and in health in general, really. So there's some links there. The Pandemic Kindness Movement is really great. There's telehealth for doctors and psychiatrists available for priority appointments for New South Wales COVID-19 healthcare workers. So go to the Medical Practitioners' Health Pathway if you're looking for that information, or if you feel your colleagues need extra support. Next slide, and this is my segue over to Owen. So one more pathway just to highlight is the COVID-19 virtual care requests, which sits alongside our general COVID-19 requests page. This is a newish pathway which we will be expanding in the future as the virtual care services get to do something other than COVID. But for the moment, this is the home for the information about virtual care, home assessment and monitoring. So make sure you're familiar with that one as well. So I shall now hand over to Owen to go through the next bits of the talk.
I'd just like to thank Kate, the Health Pathways team, and in particular the PHN and general practice for all the support through the last few months. Obviously incredibly challenging through the Delta wave, and then the transition on through to what we're doing currently. So thanks for this opportunity. I'd just like to follow on from Kate's content to talk a little bit about the current RPA Virtual Community Programme and what that looks like for us in Sydney Local Health District at the moment, and just talk a little bit about what your virtual hospital is doing at the moment and what the activities are and what that looks like. And importantly, where that sits in relation to general practice and the current model. So as introduced, thank you. My name's Owen Hutchings. I'm the clinical director from RPA Virtual Hospital. And I'll just take a few minutes just to go through what the New South Wales Health COVID-19 community model of care actually looks like at the moment, and why it looks like it does. And I'll talk about how the RPA Virtual and the other districts' clinical community COVID programs fit within that model of care. The RPA Virtual will now be running 2 clinical protocols around COVID-19, and I'll just talk about the idea behind those and what they're doing and who they're doing it for. Talk a little bit about disease-modifying treatments and just sort of direct you towards some useful resources. And then I'll just close off with some comments about the advice line and what the advice line does, how it does it, how you can use it, and how it will support you, and importantly, how to escalate for care when you feel that your patient needs the support of the virtual hospital rather than the ED. And then I'll just close off with some other topics around what Sydney Local Health District is doing with COVID in the community. So I won't spend too much time on this document. It's readily available publicly, but just so you're aware, this is the overarching document from the ACI that Kate alluded to before. We've now, with what's going on with the Omicron wave, moved to combining the adult and children programs within that. And the box that you'll see there at the bottom right hand side is essentially the role of RPA Virtual. But just quickly to run through, basically what happens is a positive RAT test, positive PCR, notification to the ministry's patient flow portals. Patients are sent their de-isolation information and self-management protocol information, which you've probably all seen or been aware of. And that really moves the model across the self-management, self-escalation protocol that Kate has described. Through that process, the registration of the positive RAT with Service New South Wales, there's some questionnaires that occur. There's a high-level questionnaire that you may have seen in the application, which tries to refine patients' clinical risk and comorbidities. There's then further triage, stratification, screening, and a second questionnaire, which then hones and tries to sharpen that information. And that's where we're currently getting the information about our high-risk groups or very high-risk groups from, as well as escalations from general practice, referrals through the GP support lines, as well as our hospital colleagues and discharges from EDs. So there's quite a few pathways into care at the moment, but it's all triggered by those positive results. So on the left-hand side there, you've got the self-management protocol for patients, and then we come down through to the bottom right-hand side. I'd just like to draw your attention to that orange, the lighter orange writing in the white box, because that's really the two primary functions the virtual hospital will now fulfill going forward. So we will be, part of Medibank's work and RPA Virtual's work is screening patients that have been referred or escalated to us for interventional therapy eligibility, primarily sotrovimab at the moment, but I'll talk a bit more about that. And then importantly, again, as Kate's alluded to, people who meet high-risk criteria based on their comorbidities, who also have moderate symptoms and may require a high level of monitoring, perhaps not possible in primary care, but not necessarily require admission or oxygen or therapy through the ED. That identifies our high-risk group, and then as you see there, it comes through to the virtual clinical services to organise the modifying therapy, and then manage as per our local pathway, which I'll talk about in a minute. I just wanted to make the point that de-isolation for all groups is now self-managed or self-de-isolation. And as of Friday night, you may have seen that there's an update to the song, which means that that now includes immunosuppression in the community as well. There's no further requirement for additional testing in the community outside of clinician-directed care. So what does our high-risk protocol look like? I won't go into this in detail, but just to give you the idea of how we describe high-risk patients, there's those lists of comorbidities on the left-hand side there, most of which I don't think will be surprising to anybody. I'll come back and talk about pregnancy and pediatrics in a little bit more detail. So we screen through the processes for those categories. We look for the symptoms. Those are the moderate symptoms described under moderate severity of disease. We put those two together, and then we deliver our high-risk protocol, which looks like this. So it's essentially patient information, reach information, contact details to the virtual hospital. So rather than patients self-escalating to the central Medibank private line, they will contact us directly. We will assess them, support them, work out what level of monitoring they need, and whether they need to go to the ED or not, whether we continue to support them by the virtual hospital, or whether they can return for care via general practice. Lots of information comes their way, including the oximeter, and then they're, as I say, advised to contact us up until that period of de-isolation with clear advice about their symptoms. Of course, if given the self-management nature of the protocol, if these patients are happy to be managed by their GP and the GP is comfortable to do that, then of course that's entirely appropriate, and we would fully support that. We then have our very high-risk protocol. So this is really talking to probably what will be the long-term function of the virtual hospital, using our virtual hospital to really target that group most at risk of hospitalization with significant comorbidities, really around cancer, active cancer therapies, immunosuppression, severe end organ disease, chronic long-term respiratory support, et cetera, and of course our transplant patients. The idea behind this group, and it probably most closely resembles what you're used to from a hospital in the home model, is that we closely monitor on a daily basis. We monitor with oximetry, and then we provide regular assessments to ensure that someone isn't requiring admission to hospital or oxygen therapy, and also to monitor people post sotrovimab. Obviously the idea behind sotrovimab is to prevent hospitalization, but making sure that we're monitoring that in these groups that are significantly at risk, and also importantly interdigitating with the specialists as appropriate and regularly, because that's another source of referral to us is the specialists themselves. So as I've mentioned, the pulse oximeter goes out, contacted daily by our virtual care centre nurses, initial medical assessment, confirmation of eligibility for sotrovimab and arrangement of the therapy if indicated, and then we manage up until the end of care. Around the discharge of care from the virtual hospital, that's now become really a clinical care consideration. So we manage based on symptomatology, clinical need, care requirements, rather than the conversation around whether someone's infectious or not. I'll just quickly touch on disease-modifying therapies. Lots of conversations. This has been quite a challenging area for some time. I know that you would all be aware as well as the other therapies you designated spoke about, and some of the others. For us in Sydney Local Health District at this point in time, sotrovimab is delivered through outpatient infusion services at RPA and Concord. They are still in the process of being established, finalised. The care protocols and referral pathways for eligibility still being finalised. But at this point in time, the easiest way to access those, if you feel you have a patient who may be eligible, is to contact the RPA Virtual COVID support line, which I'll talk to a little bit towards the end. So indications for sotrovimab currently are listed there, readily available again through Health Pathways and on the internet. It's got to be within 5 days for a not fully vaccinated person. And there is further information around where that sits with the boosters for Omicron and eligibility related to that. There is some discussion. I was involved in a meeting today, some further discussion around the age. There is a feeling that the age restriction should be removed, but we'll watch this space in terms of where that goes. Drawing your attention to the resources at the bottom, thanks to Kate for providing those, and I'll show you one in a second. For those interested, Ronapreve has a slightly broader indication of use. You have 7 days from symptoms rather than 5. It's a combination MAB therapy. It can be used as a prophylactic. So if a patient, very high risk patients had an exposure or close contact, it can be indicated to prevent development of severe disease. And importantly, there's also some additional safety information around its use in pregnancy. Talking about disease-modifying therapies, as I say, I won't go through them all in detail, but I would draw your attention to this document. It's incredibly useful. It's got very useful links. I believe it's linked through the health pathway. It talks about the MABs that we've mentioned, budesonide, role of dexamethasone therapies, or not the role of dexamethasone therapies, although that is being researched. Also importantly, talks about the evidence, what doesn't have an evidence base for use. And then I know there's been lots of questions about when to use budesonide, so it gives you some clear descriptions there around that. There are also discussions around the use of budesonide in children, and I've heard some paediatricians say recently that really it's a second-line therapy for treatment for kids who have COVID, who are having some respiratory or viral-associated wheeze. They've had their asthma management optimized, and then require additional therapy. So it has quite a sort of distinct and limited use in children at this point in time. But highly recommend you have a look at that document and spend some time with it. In terms of Sydney local health district specifically, sort of allied to but not necessarily directly provided by RPA Virtual, the paediatric program has been incorporated into the adult program. We're barely using oximetry in paediatrics at all now. It's only used on a case-by-case basis in very limited children with specific severe disease. And in terms of the virtual hospital, we're quite fortunate in our district, and we're quite unusual in terms of the fact that we have an adult and paediatric program in the same virtual hospital, so can provide care to families, and that is quite unique. But in terms of the additional support that we offer, it's now around immunosuppression, severe chronic or complex conditions. Obesity in children is a significant risk factor, as well as children with things like OSA, etc., requiring chronic breathing support or history of severe asthma. Probably one of the biggest shifting grounds at the moment is around pregnancy and antenatal care. Two factors to that. One is the maternal well-being from a COVID perspective, particularly around vaccination, and then also obviously the antenatal health of the unborn child, particularly towards delivery and in that perinatal stage. We are still awaiting on clear direction from the ministry and a clear protocol around that. There was a safety notice that was recently released by the ministry, which has sort of a very conservative approach to care that's actually quite difficult to deliver. But we understand that's currently under review given the explosion of case numbers. So I just want to draw that to your attention, because as I'm sure you're aware, there's lots of discussions around thromboembolic risk in pregnancy, the management and screening thereof, the role of Clexane during COVID, is that within the acute infection during the entire pregnancy, and then what's the additional monitoring required from an antenatal perspective in terms of things like fetal movements, bleeding, pain, additional ultrasound requirements. So we just need to watch this space at the moment until an additional safety notice is released. We have an Aboriginal liaison support officer team within RPA Virtual who are currently managing our ATSI and Pacific Islander community and providing additional social support, escalations, and high-risk support from the virtual hospital. There's also been an identified need around particularly unvaccinated, isolated, and potentially frail age that may or may not be already plugged into services. I just wanted to pick up on that point that Kate made around, we now are existing in the self-escalation model, and we know that there are vulnerable members of our community for whom that is quite challenging. Mental health would be an example. And we also just want to make sure that we don't have any unvaccinated, isolated, frail-aged at home who may or may not be able to manage self-escalation and may or may not already be plugged into traditional models of care through aged care, primary care, the hospital system, EDs, and obviously the RACFs, although that's a different subject. And we also are maintaining our outbreak management activities. So that's around additional integrated care support to social and boarding housing, as well as some of our homeless programs. My closing message and take-home message, and if nothing else went in, it would be this phone number. So this is our RPA Virtual GP Clinical COVID-19 advice line, as Kate alluded to. So just to talk a little bit about this line, so it's staffed by 2 CNCs who have additional administrative support. It provides direct access to CNCs who are very experienced in virtual COVID care in the community and have been involved for quite some time. They're very familiar with HealthPathways, very familiar with RPA Virtual's COVID programs, very familiar with the way the model looks at the moment and what services are available. So this is for clinical advice. It's for GPs, not patients, or well, I should say it's for primary care. More than happy to receive calls from practice nurses, allied health, whoever clinically needs the support, but it's a healthcare worker support line, not a patient support line. That's the place to go if you have some questions. The CNCs on that line will escalate to our COVID virtual clinical teams within the virtual hospital if required. So we have a team of senior clinicians, emergency doctors, registrars, GPs who are very experienced in this, so you can talk to them if required. It's also how to refer your patients. So if you have a patient that you think falls into the categories I've described previously, and you want additional support, you can refer through that line as well. And our team can direct you in terms of e-referral forms and processes, which are also in the health pathways, but give some information around that. And then importantly, it's currently the point of access in our district to discuss MABs. So we don't know whether it will remain that way and whether MABs will be driven through the virtual hospital ongoing, but at this point in time, reach out to our support line, explain the situation. They'll take the information, have a look at the eligibility, see whether we think that that meets the criteria, and then we will onward assess, refer, and ensure that the respiratory teams at Concord and RPA are aware of that. We're doing it that way at the moment because what we're trying to, as well as support general practice, support our respiratory teams who are obviously very overwhelmed in the hospitals at the moment with what they're dealing with in the inpatient setting. So we can provide that support through the line as well. And as Kate mentioned, it's open 7 days a week, and we'll provide access to that care. Just on that, and just before I close, then we go to questions, I did hear today that some of the oral antiviral therapies have now received emergency approval for use. So we'll watch this space quite closely in terms of what the ongoing role of MABs is when those oral alternatives become available. And then I just make the point in closing about vaccination and reiterating the respiratory message that we're hearing quite clearly around the importance of vaccination, the importance of boostering, and the criticality of that, particularly for our high risk and immunosuppressed patients as we sort of head towards the peak of the way. Thank you very much.
Thank you, Owen. Thank you, Kate. They were great presentations, all right? And so what you've done beautifully is set up for some questions, and we've got a few questions coming on board. Now, I was going to ask you a few, but I think what we might do, right, is go to our panel, the questions, and ask you guys. So the first question is, what duration of protection do you think an unvaccinated person has after COVID infection? Now, we've had this question in a couple of different forums the last couple of weeks. So what's your view on that? Can I throw to you, Owen, first, perhaps?
Difficult question, and I'm probably not the person to answer that. I'm certainly not an immunologist or a vaccine specialist. Those that know me know I'm a GP by fellowship, but my understanding from the advice that I've received and read is that the critical feature of the response to Omicron is having antibody levels as high as they can be. In terms of the timing of vaccination, the current advice is to vaccinate as soon as recovered from the acute illness. There is some discussion through the documents from public health around, someone's not considered a reinfection until 4 weeks after the previous positive test. So for example, if someone returns a COVID diagnosis and then they have another positive test within that 4 weeks, that's not considered a reinfection. So there's obviously some discussion there around 4 weeks. But in terms of actual antibody levels to Omicron in the current environment, I would be guessing.
Kate, anything to add to that? Or we?
Not really, apart from the fact that I think there's a lot we don't know yet. And there seem to be an awful lot of people, there are people getting reinfected who have had other strains as well. So I think it's yet to be known. I think the message there is everyone should be vaccinated, and even if you've had Omicron, you still need to be vaccinated and you still need to be boosted.
Now, look, the other thing, I was listening to Owen very intently there, and it was a great overview, Owen, I have to say. One of the questions that we often get as well is, you've seen a lot of, RPA Virtual rather, has seen a lot of patients with COVID, and we've now moved from, Delta's still present, but we've got Delta and increasingly Omicron. Thinking about Omicron, and thinking about how that infection carries out, are there particular points in that period do you think really need to be a bit concerned about that particular point, that patients might deteriorate? Is it day 3 or day 6 that you sometimes see people get the wobbles?
Yeah, it's a really good question. It's definitely harder to see that in the community now than it was with Delta. So when we got to look at Delta as a virtual hospital, largely unvaccinated population, we could see very clearly what Delta variant looked like, and it was very clear to see those deterioration points, where the risk was and what the risk looked like. It's a little bit less visible with Omicron, whether that's to do with vaccination, whether that's to do with the nature of the variant and how it expresses itself clinically. What we are generally seeing is deterioration sort of early, day 3, day 4, and then a sort of post-inflammatory reaction to the infection at sort of day 10, 12, 13. And we saw that with Delta as well. We're definitely not seeing the level of severe disease that we saw with Delta. We're not seeing the level of hospitalizations that we saw. We're not seeing the level of translation into ICU. And the hospitals also tell us that we're seeing a much shorter length of stay. So the average length of stay with Omicron is about 4 days. And there's a lot less people requiring, even though there's a large volume of people in hospital, there's a lot less people requiring oxygen. So I think some of those principles that we saw through Delta still apply, but as I say, it is a little bit less visible. I have heard some respiratory consultants describe much more of a sort of upper respiratory infection this time with, sore throats, headaches, earaches, sinuses, sorts of things. So whether that's amelioration of the virus in terms of its lung consequences because of the vaccination, or whether it's just that Omicron's different and behaves differently, I don't think I certainly don't know that.
Thanks, Owen, for that. Now, Kate, I've got a question for you, all right, which is, the PHN are distributing pulse oximeters. But my question for you is, as a GP, when would you give out a pulse oximeter to a COVID positive patient? What are the sort of considerations that you'd make in determining that?
Yeah, I guess there's quite a few things to think about there. I would be assessing their background medical history and working through the pathway, looking at different higher risk features. I'd also be looking at what their symptoms are like, and if they're starting to develop significant respiratory symptoms, including and in particular, I guess, breathlessness, you'd want to get some idea of what their oximetry is like. So that would be the sort of patient. I guess you're always going to have the worried well. I think in a environment where there's problems with quantity and supply, that's probably not something that the PHN should necessarily be supporting, but patients can always pick up a pulse oximeter at the local chemist or get someone to pick up a pulse oximeter for them, or they can have it in their COVID-19 preparation kits, which we're all being, recommended to have ready anyway. But yes, it largely, from a PHN perspective, be patients who one might think might deteriorate or who are developing moderate symptoms in particular.
Right. And then you get your practice nurse to maintain contact with that person on a daily basis, just check up.
Yeah, yes, either that or ourselves. As we would all know, there's no funding for practice nurses to do that, but if that was the model that the practice chose to have, where the practice nurses are looking after the cohort of positive patients, yes, absolutely.
Now, we had also some other questions on Tuesday night around this, and there seems to be a little bit of confusion. I think it's easy to clear up, but Kate, help me out. So for children, there's a bit of a range about when they should get their second shot. Right? There's a range from 3 to 8 weeks. When would you give a child their second vaccination? Is it 8 weeks?
You're putting me on the line here. I would check the vaccination pathway, and the vaccination resources would have links to what the current and updated recommendation is My understanding is it's 8 weeks, but I think it's very much a moving feast, and I suspect it's going to change.
Right.
So I would be watching that pathway pretty closely to look at the recent changes section at the top, check out the resources within the pathway, and yeah, see what the current recommendations are.
And look, you've made an excellent point, which is health pathways are being continuously updated to reflect new changes. So to those joining us tonight, hit refresh when you come into your practice in the morning, because they are being continuously updated. Now, Owen, we've got someone who's attending tonight called an anonymous attendee. And what they've done is they've posted a question, which is, if someone has COVID and then recovers completely, but then develops new respiratory symptoms within 1 month of their initial positive test, do you test again? And if so, is it RAT or is it PCR? And if positive, is this a new infection? And hence, do they have to go into isolation?
Great question. So public health will tell you can't have a reinfection within 4 weeks of the previous positive result from a public health perspective. And I'm assuming that's based on available evidence in terms of reinfection. There's also some pragmatism around separating infections, because we know that some people can have persistent symptoms, some people can go on to develop long COVID, and whether we're defining that one illness or a recurrent illness, obviously one of the features that's important around that is the isolation and what we do with that. I don't know how detailed we want to get into this, but there's a lot of discussion around the role of RAT and how you interpret the RAT depending on the clinical situation. So, Amaris talks about close contact, the presence of symptoms, what the epi-link is, what the situation is, what the clinical situation is. So the easiest way to answer that question is it comes down to the clinical situation, the diagnostic question, and what are we going to do in terms of responding to that test. So the current system won't recognize a further positive test within a month. So, you're really going to be making your decision based on the clinical scenario. Is that person symptomatic to the point where they need to go to hospital, they need to go to ED, they need the virtual hospital, or are we really managing, the symptomatic situation in terms of treatment? So I think, I'm sort of talking a little bit off the top of my head here, but I think it's really more around the clinical situation in front of you rather than the test result. And I do see this a lot in the conversations that I have, where people get really hung up on the test rather than what's going on with the patient.
Thanks for that. And I think the other issue that people are concerned about too is around, if someone has symptoms, let's say on a Sunday, and then they get RAT tested on Tuesday, when does the isolation start? In other words, what is day 0? Is it Tuesday or is it the Sunday? All right, it's a great question, I think.
It's a great question. It's the bane of my life. if and when this is all over, this is the question that's going to haunt me for the rest of my life. So day 0 technically is taken as the day of the test, and we are being quite consistent about that, because it just makes everything easier in terms of what you're doing. In the olden days of Delta and Alpha, we used to debate this. We used to say it was whichever was earlier, so you'd go from the test or the symptoms, whichever was sooner. I have heard rules such as, you can go back to the symptoms 5 days before the test, and people were making all sorts of calculations. In the interest of simplicity, our model now just goes from the test result.
Thank you for that. At the PHN, we obviously talk to a lot of GPs, and one of the things that's come back through via our practice support team is it's around GPs ringing up saying, how will I know if a patient tests positive? How will we know? So, Owen, I'm not wishing to pick on you tonight, but can I throw that one to you? And then, Kate, I'll give you one soon. All right?
Yeah. So the piece of the puzzle that's missing is GP notification of the positive diagnosis. So when currently the system is built that following the positive test, it goes through the ministry systems, the patient's informed, the patient receives all the information. So the short answer to the question is you will hear from the patient, you will hear from your patient. In previous days gone by, there may have been notification from the virtual hospital, but now that we've undergone this significant model restructure, that will not happen anymore. I have heard discussion in the last week or two from the ministry around consideration of this question of notifying the GP directly, the patient flow portal, which is the system we're using to be able to do that. And I believe the intent is that our systems will notify the GP directly in the future. We're just not there yet.
Okay. Thanks, Owen. Kate, imagine you're seeing someone or a telehealth appointment, and you can see that they're, well, not see, but they're COVID positive, having to isolate, but you're aware that they've got other sort of social needs. What would you do if they need a bit more extra support? What sort of support's out there to support, if you like, GPs arranging that for their clients who might need a bit of extra help, might be shopping, etc., like that, those kinds of things.
Yeah, well, I guess I'd explore what their actual needs are, and then use the pathway, the COVID-19 isolation support pathway, to give me the links to all the different services that are available to help. I noticed in the chat someone asked about patients who can't get medication, and there are organisations who will help with medication. The Newtown Neighbourhood Centre is one who will do that, but many community pharmacies are really happy to deliver medication. In terms of other supports, it'd really depend on what they need. If they need food, if they need money, if they need whatever, but it's all there in the isolation support pathway.
Okay. So I think that's a great point to make, which is that if you're a GP and you're seeing patients that you're particularly worried about, visit the Health Pathways link that'll take you to that pathway. I think that's really, really important because you're not alone in looking after patients who are a bit vulnerable. Now, the other thing that's coming up now, we seem to be going through this bit of a swing, which is PCR versus RAT. Now, if I get a RAT test, is there any need for me to get a PCR test? You do. One of you can go first. Take it away, Owen or Kate.
For me, this is all about high-risk settings. So if you're a patient in the community, person in the community, you've had a positive RAT test, all of the processes are built that there's no requirement to get a PCR. You don't need to get a confirmatory PCR, and you can access care through that. We can have a discussion separately about people who are unable to self-report their RAT, but you do that through Service New South Wales, and off you go. There are lots of discussions in addition to that around high-risk settings, so hospitals, EDs, aged care, outpatient clinics, cancer clinics, Lifehouse, those sorts of places. So there is some additional PCR requirement around that. There's also requirement for PCR if there's diagnostic uncertainty. So the virtual hospital does this occasionally when we have a RAT that seems surprising or inconsistent or doesn't make sense with the trajectory. Then we might consider a PCR, but we're certainly not doing that routinely.
And could I just throw in there, I think it will also depend on the timeliness of availability of testing, and that, that's sort of fluctuating. I think results are coming back much faster. I think someone told me they got a result in 4 hours today. So so I think that influences it as well.
Yeah, we've noticed that PCR times certainly seem to be improving a lot. Well, look, thank you, Owen and Kate. Really appreciate your presentations tonight.
Brenda, could I just jump in?
Yes, please.
Just jump in. I've just realised I had a typo in my slides, and mea culpa. Just to clarify that booster doses are at 3 months after primary course, not 3 weeks. So that's the same for people who've had a two-dose course or a 3-dose course because they're immunocompromised. The current recommendation is 3 months after their second dose.
Thanks,
or
Kate.
dose if they're immunocompromised.
Thanks, Kate, for clarifying that. That's helpful. So look, we're going to draw tonight to a close, but before I do this, can I say thank you to everyone for attending. Thank you to Owen and Kate for your presentations, but also being game enough to take some tough questions. Can I also just put in a plug for on the 22nd of February, make sure you sign up to our next webinar, which is the COVID infection prevention triage and risk management and general practice. How to keep your practice open in COVID times. And then on the 7th of March, we've got triage for general practice. Both great topics, and really encourage people to sign up for that. Once again, thanks, Owen. Thanks, Kate. We're right on 7:30. So we'll draw tonight to a close. And thanks everyone very much for attending tonight. Thank you all.
Thank you.
Thank you. Good night.